I've been out at the Addiction Center. I'm not an employee there. I basically rent space from them and see folks. They refer to me Texas, just south of Denton, and basically been out there about 13 years seeing folks. So I utilize quantitative EEG. That's a big part of my practice is out there. I'm there 4 days a week, usually mornings a week, seeing folks 4 times a week, and then have my own clinic here in Denton that I'm in the afternoons. So kind of another specialty I work with is the children from Child Protective Services, most of them with the attachment issues. And but that's another thing for another time. But right now we're going to move into talking about EEG patterns in addiction, substance abuse, and sex addiction. And sex addiction, as you all know, is an area that's really increased over the last several years, and I feel that's predominantly due to the availability of the Internet. It's kind of a personal thought on my own here. And I've done a lot of work with sex addicts. As a matter of fact, that is the reason I originally got started at Sante Center. So we'll talk about a little bit of that as we get through here as well. Well, let me see. I'm not getting this. There we go. All right, we're going to start with the neurobiological basis of addictive disorders. It's well established through research that addictive disorders can have a common and inherited predisposition, but not always. Examples are defects in dopamine receptor genes that are predisposed for alcoholism and/or drug abuse. This was Dr. Bloom brought this to our attention through the reward deficiency syndrome work he did and published in 2006. We can see that it's also related to specific patterns, that the basis of addictions can be related to the specific patterns of the EEG abnormalities or phenotypes, and this was brought to our attention through the research of Dunkelman, Johnstone, and Lunt. We'll also see that summary of EEG, QEEG research findings that there are similar EEG abnormalities associated with alcohol, cannabis, and heroin addiction, and Bauer study talked about this. Basically, these substances all are central nervous system depressants, as we know. Some of the EEG abnormalities that we see in alcohol abuse, the most common is a low voltage fast EEG pattern. Basically, this will look for those that are doing cues quite often, or you may even see it when you're collecting data in a session or running a session, and it'll quite often almost look like a flatline EEG. And it's kind of surprising to me that most people can't associate that with the addictions, but then again, I'm in the addictions field on a regular basis. So, you see that on listservs, people will be asking about that, and there's all kinds of suggestions about it, but very few people will pipe up and say, have you checked the history, that it's probably based on a history of alcohol abuse, or it can be a person that doesn't use alcohol but has what we call the familial pattern of alcohol abuse, which is a low voltage fast pattern. Also, other research is found in the frontal and occipital areas a reduced power in alpha and theta, slowed alpha frequency, and the excessive fast beta, or high beta as we may call it. And all of these patterns are associated with the central nervous system hyperarousal. You'll see a similar hyperarousal pattern in heroin abuse. The heroin addicts in early abstinence show the same increase in the beta and a decrease in alpha as the alcoholics do. And they'll also show an increase in low amplitude delta and theta. Substances that act as the CNS depressants, they tend to be preferred by individuals with hyperarousal, or as you may know it as an overarousal pattern. Sympathetic nervous system is dominant. And this would be, such as drinking alcohol, how it increases alpha when that happens. And a lot of pot smokers, the chronic cannabis use will also show excessive alpha, and it's usually in a slowed alpha frequency, though. The hyperarousal patterns can be seen in EEG as well as other psychophysiological measures. What we talked about a little bit ago on the low voltage fast pattern, the deficient low amplitude slow waves, beta and alpha. And we will see this with the excessive high beta, the fast frequency activity. We'll see a cortical excitability hyperarousal pattern, and it's one of the most common EEG phenotypes, and like I mentioned before, this is something that one can inherit. So you can thank your folks for that sometimes, or your relatives. It may also be identified in the power spectrum recordings of HRV as a sympathetic parasympathetic balance indicator. Here's an example of a low voltage fast EEG, and often you will see these. These are at a 50 microvolts, so it's been cranked up pretty good. But if you're running that at 100 microvolts, it's going to look, you know, much lower and much flatter. And it's going to really throw some people for the first time they see it, because people are like, wow, there's just nothing going on there. It is. There's just not any strength to the signal. There are consequences of the cortical excitability, the hyperarousal. The EEG is usually seen as a low amplitude fast pattern and is in an underlying physiological condition common to many clinical disorders: anxiety, obsessive compulsive, addictions, reactive attachment issues, trauma disorders, and others. You can see this quite often, this pattern in PTSD clients or patients as well. It's a transdiagnostic pattern with common symptoms. Biggest one's the cortical excitability, predisposition to addictions to alcohol or central nervous system depressants, as well as other disorders. And it has a pronounced frontal central excitability, the excessive high frequency beta, greater than 20 hertz, especially at CZ. And this is the best predictor of a poor prognosis treatment and relapse in substance abuse. And this was in Bowers' study is the one we usually cite. There's actually two there, but Bowers is the latest and discusses what we were talking as far as CZ high beta is one of the best predictors of relapse. Take a look next at some of the addictive substances associated with the CNS under-arousal patterns. Slowing is a big part of what we see there. Oftentimes you'll see it with high beta as well, along the vertex, over anterior and posterior cingulate areas, and excessive slow waves frontocentrally. It often is accompanied with ADHD and depression. And it's likely an under-arousal pattern, but there's not necessarily a predisposition genetically. Chronic stimulant abuse will end up with being alpha and delta deficits, and you can see the studies on that have shown that. EEG patterns in methamphetamine addiction, basically meth addicts will show significant power increase in delta and theta bands compared to non-drug using controls. 2 or 3 years ago, we had a female at the addiction center who was a chronic meth user for 20 years, and they were basically seeing symptoms of around age 40 of early dementia with her. So they had me do a quantitative EEG on her, and basically what we were seeing was pretty much global 6 to 7 hertz activity, which would account for the deficits they were seeing. You'll also see psychomotor slowing and frontal executive deficits, which is what they were seeing in the lady I was talking about. EEG patterns found in stimulant addiction. EEG is highly sensitive to neurotoxicity effects produced by the psychostimulants. Cocaine users will show increased alpha power frontocentrally, and also you will frequently see it in the parietal region. I actually will see it there probably more so than anywhere else, and I'll show a slide here in a minute with that. Meth users show increased power in theta and delta, and the increase in theta power is usually associated with reports of a high in the use of cocaine. Cocaine's interesting in itself. A lot of times I'll talk with the patients at the addiction center that are on intake and ask them in regards to cocaine whether they were using it to speed up or slow down. And that kind of gives me an idea of what we're starting to look like or look for in the brainwave activity before we even start the quantitative EEG. Implications of the slow or fast EEG activity, usually we'll see along the vertex sites. Basically you see a vertex pattern where there's a slowing of 2 to 10 hertz and fast waves greater than 20 hertz. And we'll see this along FC, CZ, PZ, and OC. I usually see it mostly around FC and CZ. PZ will be, and I'll talk again on that, but I usually see that with drug abuse. Alcohol is usually CZ and sometimes FC. It's usually associated with projections from the dysregulated limbic areas through the anterior posterior cingulate, and associated with compulsivity, obsessive behaviors, rumination, and anxiety. And the one thing I've noticed over the years is in the patients at the addiction center, there's a tremendous amount of the anxiety. That's the biggest reason they're referred to me. And then as well, the obsessive compulsiveness that goes with that. And if you think about it, a craving is an obsession, and the compulsion is the acting on the craving. We don't necessarily hear a lot talked about that, those types of behaviors, the anxiety, the OCD issues, in the addictions literature, but it's pretty much an underlying pattern that we see within the brainwave activity. Here is the vertex pattern we were talking, the slowing. As you can see, the front to back midline, we're getting a lot of activity down through here. And if you'll look here, especially around 7 hertz, 6, 7 hertz, and even at 8, we're still starting to see that. So that a lot of times, the way I'll talk with them, it can be the obsessive compulsive traits, may not be a full-blown OCD disorder, but you do have the traits that go with that, the rumination of thought, cravings, some of the actions, not being able to let go of things, etc. And you can see that the predominance of activity is in the slower frequency ranges on this particular slide. The polysubstance abuse, the PZ alpha, is the big thing I see for drug abuse, is the way I usually put that, and whether it's prescription or street drugs. And it's very easy to see this pattern show up in the maps. We still may see a little bit of the slower vertex activity, but the predominance of activity is going to be in this central posterior area. In the alpha range generally. The interesting thing that I've seen over the years is you can see that in children as well who have sensory integration disorders. Now, I'm not trying to make a leap. I have no idea. Perhaps it would be a great research project for somebody to follow kids that have this pattern and see if they have a propensity towards using drugs. But it's kind of interesting to see that the two patterns are the drug abuse and then in another area, the sensory integration. Here are a few other abnormal EEG findings for drug abuse. EEG coherence connectivity patterns are disrupted in chronic drug use, and the P3 evoke potential abnormalities found in persons with substance abuse or high risk to develop substance abuse. There are consequences of disrupted connectivity patterns, coherence abnormalities, poor integration of the cognitive functions needed for the effective problem solving, and deficits in abstract conception, formation, and regulation of affect behavior. Talk about some of the EEG patterns for other forms of addiction. Back in 2005, I believe it was, we presented at the International Society for Neurofeedback and Research data that I had collected on 32 sex addicts, all males. And we had not written this up, but we did at least do the presentation. And here's some of the summary of our QEEG and Loretta findings for sex addiction. First, there was a study done by Corley, Walker, and Walker in 94, and then another one by Floor Henry in 91. But Corley and Corley is Deb Corley and Rip Corley. Rip is no longer living, but they were the founders of Sante Center for Healing and are fairly well known in the addiction circles. Walker and Walker is actually John Walker, as most of us know, John from the neurofeedback world, and I believe the other walker on that was his son at the time. What they found was there was reduced overall power and decreased relative power in the slower frequencies, increased frontocenteral fast frequency beta, reduced coherence between the hemispheres. We saw that as well in ours. And then S. Loretta showed abnormalities in the limbic system structures, cingulate gyrus, as well as the prefrontal area. 32 patients was a small sample. You know, since then, if I wanted to go back and redo it, we've got a lot more folks that I've done maps on over the years. But it was interesting to see that because it was able to basically validate a lot of the things I was seeing clinically and starting to understand with that. This is a Z-scored relative power, FFT relative power, and a 51-year-old sex addict that I was working with. As you can see, we've got the low theta in the frontal. The beta is showing to be more or to be stronger. But what we're seeing is here in the beta as well, 18 to 25 hertz. We've got some central beta and then a little there on the right frontal, which that very well could be on the right frontal, E and G showing up. Sex addiction EEG pattern has features of both a central nervous system hyper and hypoarousal pattern. We'll oftentimes see temporal slowing, especially at T6 in the right posterior temporal area. This is associated with poor social perception and interpersonal boundaries. And the pattern can produce the other thing is a lot of these folks, and this is coming out of what we call that vertex activity, usually in the frontal, is slowing activity 2 to 7 hertz, and then perhaps 20 to 30. Usually at SC, CZ is the obsessive compulsive issues that you see with sex addiction. And that is a very big part of it, which also leads it back to being an anxiety issue as well. Here's kind of a summary on abnormal EEG patterns related to addictions disorders. Patterns are associated with the hyper or hypoarousal that may predict addiction to specific classes of substances. More often seen are mixtures of more than one pattern, especially in cases of polysubstance abuse. So how are hyper and hypoarousal patterns revealed in EEG Z-score maps of specific psychiatric disorders? I'm having trouble talking. I need to get a drink of water here. Including substance abuse, basically through comparison of typical EEG patterns found in the New York Database of Psychiatric Disorders. This is Eroy Johns from the NX-Link database and the work he did to create that. And this was a slide that he had put out. Basically what you see up here is the normal. Now, I don't know what was going on for them at T6 and the theta. That's not necessarily something I think that's per se normal in there. But as you look down through with the unipolar depression, and then we start to see bipolar where we start to see increases in the beta frontally. But here with the alcohol patterns, what we're seeing is deficient slow activity in the delta, especially in the theta, and even the alpha. We see it, posteriorly here in the occipitals. But look at this beta over here, how strong that is increased. And one of the things you can kind of do is take a look at this and see how similar the bipolar disorder looks to the alcoholic on there. A little bit interesting to take a look at that. Have the schizophrenic, mild cognitive impairment, and dementia down here. But again, for what we're talking about, this really illustrates the amount of beta compared to the other activity and the imbalance that you can see. History of neurofeedback treatment for substance abuse. Basically, most people think of the Penniston protocol. This was based on EEG studies showing alpha, theta, and beta abnormalities in alcoholism. The process focused on increasing alpha and theta. Eugene Penniston, was a psychologist who was with the VA at the time. I believe he was in Fort Lyons, Colorado when he did this work. He ended up going to Menninger to be trained in this process by Elmer Green and Del Walters and their crew there at Menninger at the time in Topeka. I think Richard put this in his book, but we got to know, my wife and I got to know Gene very well. He was actually transferred later from Fort Lyons to Bonham, Texas, which was about 80 miles from where we're at. And when we would do trainings at the University of North Texas for neurofeedback, Gene would come down and speak and hang out. And so we got to talk with him a lot about this. And he actually was given this protocol when he was doing a session in training. He saw it come to him and what he needed to do and brought it back with him out of the session and moved forward with it, which is really kind of cool. Basically, what he did is increase the alpha and theta at O1, left occipital area. One of the things that I've found with Elmer Green, he actually started at O1. I know there are some folks, I think, the old EEG spectrum folks would do PZ, but O1, I believe, Elmer Green talked about that. He was trying to link to the visual centers so that you could get imagery to help with the process. And we know that when you move into a crossover, it's not unusual to have imagery with that. It could be positive or not so positive imagery, but it's a great learning experience. Penniston, as I mentioned, was in the VA system. He developed this process with VA alcoholics. Most of them were Vietnam veterans. Tremendous amount of PTSD, substance abuse, multiple hospitalizations with these folks. And they were anxious to find something that worked. Multimodal protocol, he used both peripheral and EEG biofeedback imagery and supportive counseling. Alpha theta neurofeedback is deep states training. John Demos refers to it as that, and I think some of the folks from, if you look on the BrainMaster equipment, they've even got protocols that are labeled deep states. The term's been around a long time. It's an eyes closed process. Alpha theta can enhance treatment of hyperarousal disorders and improve the effects of psychotherapy. It's also used for performance enhancement, exploring consciousness states, transpersonal experiences, etc. Here's a summary of Penniston and Kokoski's 1989 study. Basically, they had a lot of Vietnam vets with PTSD, 20-year history, an average of 5.4 hospitalizations for alcoholism. All had elevations in depression and several other scales on the MCMI and 16PF, and they also measured the serum beta endorphin levels. Had 3 treatment groups, an alcohol control group with 10 and a non-alcohol control group with 10, and a brainwave training group with 10. Here is the Penniston protocol, the way he initially did it. 8 to 10 pre-training sessions to learn relaxation through the breathing. Basically did temperature biofeedback with autogenic instructions. Sessions began with the reading of a script that contained autogenic relaxation instructions, personalized guided imagery for cognitive rehearsal of alternative responses to problematic behaviors. They would have alcohol drug rejection screens, see ideal self, ideal behaviors, and then he would just usually follow that up and end the script with a "just do it" phrase. Now just do it. And not endorsing Nike on that, but you may have been ahead of Nike on that. I can't remember there, but basically using it as an induction script as well. Do a minimum of 30 alpha theta biofeedback sessions, 5 times a week, 30 minutes each. These are eyes closed, auditory feedback. Have separate tones for alpha and theta. 75% to 80% feedback on alpha and 20 to 25% feedback on theta. I personally will run about 40 to 45% on theta now, and I think Bill Scott might be where I get the idea from him, the work he's done in alpha theta as well, but I like to run just a little higher on the theta. And Peniston was, at 01 on that. I think Bill and the authors are the ones that moved to PZ. And I asked Siegfried Othmer why there was a move to PZ, and he told me that they kind of felt, and those of you know Siegfried, in his speaking manner, he basically says that people can attain grace by closing their eyes, which basically what he meant was you could get alpha to increase by closing one's eyes. But I'm not so sure. Many of the alcoholics that I work with cannot have that happen. And so they went to PZ because they thought it would make it harder or make them work a little more to make it happen. They get good results at PZ, so it works well there. What I see a lot of times with, like I said, the substance disorders, the drug disorders, drug abusers, the alpha you see at PZ will be slowed alpha, usually 7 to 8 hertz, maybe 9 instead of a more healthy alpha that's a little faster. But like I said, I'm a traditionalist. I like to use 01 myself, and then I may bump up the theta up to about 40, 45% on the feedback then. Each session that Peniston did was followed by a discussion of reactions to feedback, of any imagery, insights acquired during sessions, supported counseling. You can see the location of 01 there if you're not sure. This is a 1 and 5 year follow-up on the results, and you can look at the graphs there. Basically what you're going to see is that the alpha theta group did about 90% better than the alcohol controls. 9 abstinent, 1 relapsed, and all 10 relapsed on the alcohol controls. They also did studies of PTSD on the same groups, and that's how Peniston came to find that you would be able to resolve PTSD with the alpha theta process as well. Here's Peniston protocol replications, and you can look down through there. My wife, Callaway and Bodenhammer Davis. Jeannie's lab actually started to follow up Peniston's work. She'd gotten a grant from the Texas Commission on Drug Abuse, TCADA, Drug Abuse and Alcohol. One of her former students at the time was the director of TCADA, Bob Dixon, who is now retired, and he approached Jeannie after the literature came out on Peniston, and Jeannie had seen it, and basically they put together a grant and funded the start of the neurotherapy lab at UNT, and then Jeannie's study used high-risk probationers from Benton County Probation here, and as you can see, actually on a 10-year follow-up, a lot of these have now. They follow theirs up at 10 years, and they're still at 81% on those folks. The other thing is down there in the red, you'll see the studies also consistently report subjects remain in treatment longer and complete treatment at a higher rate than controls. And that's one of the things I talk with the patients at the Addiction Center is how this process can actually move them through their treatment faster and as well keep them more vested in their recovery. I believe Bill Scott had done a study, or one of his studies, one of the measurements they had was reduction in AMA, which is basically leaving against medical advice, leaving treatment against medical advice, and they saw a reduction of 18% in AMA on that. Subsequent modifications to the Peniston protocol, polysubstance abuse more commonly seen today. So they basically thought they need to address a broader field than just the alcoholism. Current changes in the protocol address its known differences in the EEG pattern for different substances of abuse. First research that was published on the modification was Scott, Kaiser, Othmer, and Sidoroff. And basically they achieved 77% abstinence rate at 12 months plus significant clinical improvements in TOVA and MMPI-2. What this one was actually instead of doing the temperature training sessions, they moved to doing, I believe it was FP1, F4 bipolar hookup, and it may have been FZ in there as well. And then later on, many of us just started using C4 SMR to be able to do the induction, the start of it, to get people used to the process instead of using the temp training. Temp training, though, if you're working with PTSD folks, can be very, very helpful, because what you can do is use that as a tool to give them so that they will have something to help if they start to feel these issues coming up when they're not, in the office, and they can go into their diaphragmatic breathing and help to relax them down and help ground them back. Coming back to the Scott Kaiser protocol description, I guess I should have gone to the next page, and I would have seen it here, but the pre-assessment with TOVA determined if inattentive, the hypoaroused, aroused, or impulsive hyperaroused. They started with author bipolar protocols based on the TOVA findings. They did not use quantitative EEGs. Either FPZ to C3, 15 to 8, 2 to 7, or a C4 PZ, 12 to 15 up, 2 to 7, 22 to 30 down. Reassessed with the TOVA after 10 sessions if normal. They switched to alpha theta protocol PZ for 30 sessions. They used alpha at 8 to 11 hertz and theta at 5 to 8 hertz. They used a relaxation, induction, and imagery scripts. The Scott Kaiser modified Peniston protocol added to Peniston's original protocol the 15 to 30 hertz, inhibiting 15 to 30 hertz throughout the 30 sessions, and initially inhibited alpha that exceeded 12 microvolts and reordered 15 to 18 hertz until achieved first alpha theta crossover. And my wife and I kind of decided maybe that should actually be a theta alpha crossover, because theta amplitude exceeds that of alpha. And then they would begin rewarding both alpha and theta and inhibited 2 to 5 hertz to discourage sleep. Now, my wife has done some research that was actually published in last year in the Journal of Neurotherapy on crossovers. And one of the things they found is you may not want to inhibit the 2 to 5 hertz to discourage the sleep, because what they found was that people that perhaps were in that range and looking like they were asleep may have been extremely deeply relaxed and actually having a transpersonal experience while they're doing this. They were able to, you might want to grab that article and read through it if you're interested in this area, because they were able to explain different findings of different frequency ranges in regards to crossovers based on the notations they had from processing these sessions after the clients would come back in the sessions. I'll talk a little bit more about this if we have time at the end. I don't have this data on here, but we can talk a little bit more about the results they found towards the end. And we give the listing there for the Scott et al. Article for the full details of the protocol. QEEG-based protocols for substance abuse and other addictions. I've started doing this. There's others out there as well that I found were doing pretty much the same thing. You do the maps, you treat the abnormalities seen in the individual QEEGs. Roger Dubuis has a 2002 paper comparing the Peniston protocol to QEEG-based approach, and the Q had the best results. Treat the phenotype patterns typically seen in the QEEGs. Persons with addictions generally going to be the low amplitude fast or the vertex excesses. And then you treat all frontal central abnormalities seen in QEEG prior to doing posterior alpha theta using basic Peniston protocol. And what I have found with that, if you do this with the quantitative EEG, you can basically end up having to do many, many fewer alpha theta sessions this way. You can see the rest of it there on the TOVA results, et cetera, and I'll talk a little more about that process. Well, here I will. And here's kind of what I have come up with for using at the Addiction Center, the process that I follow. I'm not saying everybody needs to jump out and do this. That's kind of up to what they want to do. But as I mentioned, Sante Center for Healing, it's in Argyle, Texas. It's a private residential treatment center, predominantly polysubstance abusers, sex addicts. All patients that I see are referred to me by the center's psychiatrist. Presently, they have 3 psychiatrists on staff, I believe on a part-time basis. The case managers or treatment team may suggest or refer the patient, but the orders have to be written before I can move forward. I perform a QEEG. I don't necessarily perform a TOVA on all of them. If requested, I will, but for the most part, I'll just move forward with a QEEG. And then they do have on-site testing they can do as well if someone requests that. And most of the maps that I do show a combination of the frontal slowing, the vertex fast slow activity, posterior and or temporal alpha elevations. Here's the clinical approach that I like to use. Oftentimes they will require the modified Peniston approach. Basically what I like to do is treat the vertex first, decreasing or inhibiting the fast slow activity, and starting at FC, and it's not unusual for me to stay there for 12 to 15 sessions if needed. It takes these folks sometimes quite a while to be able to start self-manage and get this under control and start to see the decreases and the decreasing of the variability. And when I talk about decreasing variability, usually if you look at a graph and as it gets smoother, that's what we term as decreasing the variability instead of seeing the big ups and downs in the theta or the high beta or the other frequency ranges that you might be training. What I'm trying to do with the FC and CZ work is a couple of things. First off, I want to decrease that excessive activity, but the other thing is as we do that, we find the frontal lobes basically start to come online and start working much more efficiently, or maybe start working for the first time in quite a while. And what this helps is with treatment altogether. You start getting better sleep, you start getting better judgment, better action as the person becomes involved in their treatment. So it's kind of jump-starting the frontal lobes. We're going to improve attention, we're going to reduce impulsivity, compulsivity, improve the judgment, the insight. Next, I'll usually move back to the parietal temporal areas, and usually on the right. I want to reduce the slow and fast activity. I may even put in a 12 to 15 hertz enhance in this as well to basically help with calming, reduce sensory integration issues, work on trying to reduce the interpersonal boundary problems. And then I will move into, after having done those areas and everything's looking good, I'll move into the Peniston protocol. If it's possible, I actually don't do a lot of alpha theta at the addiction center. That may sound sacrilegious, but one of the problems I run into out there is you never know how long somebody's going to be there, and it's difficult to do your planning to be able to jump right in. I don't feel comfortable starting alpha theta, and then right in the middle of it, somebody may basically get upset or they're due to leave, and then you've got somebody in the middle of a treatment. Perhaps they're just starting into crossovers and they're a little bit vulnerable, and I would rather go ahead and stabilize them with the QEEG and then be able to go in with the alpha theta on a shorter duration on the back end where they're much more stable. As we talked about with the Peniston protocol, we're going to increase the alpha and theta posteriorly, and basically that kind of brings treatment around and helps gel things. What I have found is by doing that, I'll do anywhere from 25 to 30 or so eyes open sessions, let me put it that way, cleaning the head up as I describe it. Then I move into the alpha theta, and I can usually do anywhere from 4 to 10 alpha theta sessions and get them to where they need to be, providing there's not a lot of PTSD. And what I've found is in severe PTSD, it will still take more than that. But it's not unusual to have within 3 or 4 sessions, or even before that, people moving right into crossover activity and basically moving through the alpha theta process very quickly. Part of my theory or thought on that is that even with when Peniston was doing the 6, 8 to 10 sessions of breathing, or you're doing the C4 SMR or the other modified protocols on the front end, and then you were starting to establish the patient-therapist relationship and the trust. And even when you start to do alpha theta by itself, you're not going to start to see crossovers occur until you're around 8 to 15 sessions. And then you will start to see them build and be able to hold the duration of the crossover longer. And what I think is happening at that point is that therapeutic relationship is being built, and you're able to do that eyes open as we move along, and I think that's what facilitates moving in to the crossover so quickly on the back end doing the alpha theta. As well, the brain is used to doing the neurofeedback, and it kind of knows where it needs to go, and it moves very quickly as you get further along in sessions. And I'm sure you see that in your regular training as well. Okay. Here was the rationale I was talking about for treating the Vertex activity. Basically, it engages frontal inhibitory, cognitive, executive functions of the cortex, gives clients capability for greater self-regulation, cognitive participation in the therapeutic process, taps the anterior cingulate gyrus, gateway to the limbic areas of the brain that regulate emotions, the emotional memory, affect regulation, reduces anxiety and irritability, and stabilizes mood as well. The central training to address the obsessive-compulsive traits, the compulsion craving aspects of the addictive disorders, and reducing high beta CZ addresses the hyperarousal and anxiety that predispose to relapse. C4 for calming, if overtraining, may present as agitation occurs or continues with frontal training. And I've actually even started doing more right parietal P4 for calming, basically doing what we would refer to as an SMR protocol on the motor strip, enhancing 12 to 15 hertz and then reducing 20 to 30 and 2 to 7, inhibiting that. And it seems that, through the parietals, you've got a better connection with the body, and you get some fairly strong relaxation from that. Guess I'm always ahead of myself a little bit on saying those things than I am with the slides, but again, here it is. The parietal training, I'll reduce PZ alpha to basically work on the drug abuse, cocaine, meth, prescription drugs, sex addiction. And as well, it's not unusual in talking with these folks to determine that they have some fairly serious social, they do have some fairly serious social integration issues, but also sensory integration issues. And that's, if you remember, I mentioned that we see that activity at PZ as well. And then here's where I talked with P4 for calming, as C4 doesn't get you there. Temporal and occipital training, decrease the excess alpha at T6 to address the social anxiety, the limits, boundary issues, interpersonal communication, and social integration problems. And we moved last to O1 for 10, 15 sessions of alpha theta training using Peniston protocol. Here's a general neurofeedback protocol to use and to see about following when QEEG is unavailable. We basically base this on the most common QEEG patterns seen in the polysubstance abuse population. Reduce the frontal and central abnormalities first, usually reducing the slow wave activity, as I talked about, 2 to 7 hertz or 2 to 10 hertz. and fast frequency beta, the 20 to 30 hertz at the vertex sites, FC, CZ, and PZ. Reduce the central parietal and posterior temporal T6 alpha if excess present, and continued high beta inhibit. I usually use a high beta inhibit on pretty much everything I do. I kind of call it my safety valve, and I may not put it into the protocol real stringent, but I always let it be there because what I don't want to have happen is I'm, in a sense, trying to lower those slower frequencies that electrical activity may decide to start to move into the high beta range. I'd much rather see it go into the middle ranges where it's more cognitive functional ranges. And that way, if I keep that inhibit there, then what we're able to do is kind of have what I call as the safety valve. The occipital O1 alpha theta training, and then as well, again with a continued high beta inhibit. Also, some of the supplementing of different modalities to use is heart rate variability, and I talked about this a minute ago. I bring that in early on your training. These days, you can get something like M-Wave or HeartMath and actually run it at the same time you're running the EEG session, eyes open, and it's not unusual. I train two modalities at once with that. You're going to teach them the breathing. You're going to help decrease the hyperarousal and increase the relaxation. And the other thing is you give them a major tool that they can use if they basically start to have a panic attack or extreme anxiety. They can go into their breathing and help to reduce and basically get control of things again. Cranial electrical stimulation, CES, I use AlphaStim. Use that between the sessions for the patients. It will help to increase alpha and decrease the beta. As you can see, it'll help ease withdrawal, improve sleep, and reduce anxiety. And I believe that it's FDA registered for those issues as well. Getting to the end of the process here, as you can see, I just want to take a moment and thank my wife, and very proud of her now in her retirement. She's basically become the professor emerita there at the university, in her department, University of North Texas Neurotherapy Lab. And we usually do this as a double presentation. Did so actually last Friday at the Texas Biofeedback Society meeting. Did a 3-hour workshop on this, so it's always enjoyable to do this, but I just want to take a moment and thank her. And here's my contact information. Feel free to call me, email me, and be glad to answer questions. I'll talk with Dr. Sutar or Rob on this about if you would like the PowerPoint copies, I can do a PDF of the thumbnail and get those out to you either through myself or through them. But at this point, that's the end of the slideshow. And I guess we can open it up for questions if people have that, or if you need to get on to your next sessions or lunch or whatever. We'll go from there.
We'll take a few questions, Richard, and I've already sent out a reminder to, if you'd send us the PDF version. Some people have already written asking for it, so send it to me and I'll go ahead and distribute it.
Yeah, I'll do that this afternoon to you.
Great. Okay, questions, folks. We've got about 5 minutes or so.
Dr. Davis, I'm curious what you do with folks that continue to smoke marijuana, and how do you encourage that kind of withdrawal, or is that an issue that you've seen, and what kinds of effects marijuana smoking?
Well, one of the things I didn't really go into much during the presentation, I'm in a controlled environment at the residential addiction center that they're keeping everybody abstinent, and that's the beauty of a inpatient facility. You know, they're supposed to be abstinent anyway. Quite often they find a way to use, but you're going to find in practice very, very difficult to be able to keep folks that aren't necessarily highly motivated to stay clean and sober and show up, and that's the difficulties there. You'll probably find that treatment rates are 20 to 30%. I don't have any grand things that you do to keep people from using. Pot smokers are probably more of the chronic folks that are going to be smoking because they do find help from the marijuana to relax them down. I certainly don't encourage them, but we talk with them. The other thing too is you can see it in the EEG, and quite often that'll start to scare them enough that they may not at least use before they come in. Sorry I don't have a lot of help with you on that, but that is a very tough one, and that's one of the problems of doing things, you know, in your own office. You don't have a controlled environment to help people stay clean and sober between sessions. Next. I'm going to get off easy.
Any other questions, folks?
I had a question. Yeah, I had one. Dr. Davis, thanks for a wonderful presentation. It's very helpful. What do you do if you start getting people with alpha that just doesn't want to come down? When you get to, I see a lot of these type of people these days where you want to do alpha theta with them, and then alpha just stays real high.
Well, is it posterior alpha that's high? Is it at O1 or PZ where the alpha's high?
Yes.
Okay. One of the things you can do in that regards is only train theta up and just leave the alpha where it's at. I mean, you know, use it to your advantage. It can be very difficult to bring some of that alpha down. Often if alpha is in the PZ, you might be looking at folks with high anxiety. You know, is the way I see those as well. But some of the things we've done is if the theta or the alpha is out of balance, I'll put it that way, you can train one or the other up separately until you can get some balance on it, and then you might go about working both of them together at the same time. So, you know, hopefully that helps, and you understand what I'm saying on that?
Yes, I do. I'm thinking, you know, wouldn't this be a good protocol?
I lost you on the last part of that.
I was thinking this sounds like would be a good protocol.
The work I love, that's probably my favorite area, is working with PTSD folks and using alpha theta and helping them through, and I've had some very incredible experiences. One of the things I didn't bring out during the talk, and I'll address it real quick here, is my wife and I have a very strong belief that if a person's going to be doing alpha theta work, you really need a good, basically counseling or psychotherapy basis. And the reason is for the possibility of abreaction. I mean, one of the first clients I ever worked with was a first Gulf War vet, A-6 pilot. His navigator best buddy had been killed, and he caught flak. This was the last day of the war. We were in sessions with him for PTSD, and basically he all of a sudden sets up in the middle of it, rips the electrodes off, grabs the trash can, and starts filling up. And, you know, these are the types of things, I'm not trying to be graphic here, you know, some of you are doing lunch probably, but the thing is, the point I'm trying to get across there is these are the types of severe abreactions you deal with. You're going to need a good psychotherapeutic basis to be able to help ground these people and move forward. So that's just one thing I like to put out there. But as far as using alpha theta for PTSD, yes, very much so. And Peniston actually had a second study he did that this was a side effect that he found that these Vietnam veterans were basically severely traumatized, were resolving their PTSD during the sessions. Really fascinating stories that he has.
Dr. Davis, this is Martin Gremlich. Can you hear me?
Yes.
Okay, I have a question to the abreactions. Do you actually see symptoms like do you observe like increased breathing rates or heart rates or something, so you could actually interrupt the training? Could you maybe give us some hints on that?
And what you want to do is grab that study my wife did. Basically what they found by going back and looking at old clinical records and the graphs of the sessions is that you need to have, you know, it's an abreaction, to be able to, well, what you're going to see is what I see when I do sessions. You'll start to see some rapid eye movement under the eyelids, and you'll start to see increased respiration. And then what you'll do quite often on there, you'll start to see the theta really kind of pull down in the graph. I mean, it's pulling down even though it doesn't want to, and you'll start to see the alpha climb. And, or excuse me, it'll be the other way around. The alpha's pulling down, and the theta's climbing. I was saying saying the wrong thing to what I was visualizing. And what you see, that alpha starts to come down against itself, and then the theta really climbing up and sustaining over the alpha. And one of the things is, if you see theta increase during that time, more than likely they're going to bring those memories back with them. And when the session's done, they'll be able to retain the memories. And you may even want to add in there a way to enhance some of the beta so that that can come along with it. But yeah, and these can last, can be very short, and then they can be very long in the reactions. Did that help answer the question?
Very much so. I'm treating people with a different type of PTSD here. That's sexual abuse victims, and I do see more and more of these type of abreactions. They sleep very bad after they carry the stuff into the next days and don't know how to help themselves. So your warning to have a counseling with it is very, very important.
Richard,
and one of the things I'll say on that, on the sexual abuse, those folks can be some of the most difficult cases that you'll work with in regards to the trauma resolution, with the alpha theta, with neurofeedback. And I've even had, out at the addiction center in my practice, females who have abreacted, eyes open, doing SMR training at C4. And, basically what you're doing is pulling down their defenses when they start to relax, and everything starts bubbling up, that anger, the fear. And I've had them basically jump up and want to run out of the room with the equipment still attached. And so, I mean, that's just something to keep in mind. You got to take a look at the patient's symptomology and where you're headed, and kind of have the basis to get there.
Good. Richard, I'd like to just ask as we wrap this up, my experience so far with the people that I've talked about working in addictions clinics across the country is that they're combining this combination of preliminary fast wave training, usually with a QEEG these days, and then the alpha theta at the end. I mean, that's what we use. Would you say that's the primary modality of working with addictions when you use neurofeedback at this point?
Probably so. I mean, it is for me, and you may have more contact with the folks out there than I do, but I mean, I'm not the only one doing this, as you're saying, and it's just something that I kind of, after starting to do cues and stuff, saw and went, I really need to be doing this, and went about it. And again, my situation is difficult for me to do a complete alpha theta process at the center because I don't know when I'm going to go out there if my patients are still going to be there the next appointment, because they may check themselves out, or they may be leaving shortly because they completed treatment, et cetera. So I do think that it's a very economical way, and I have been surprised at how fast you can move through the alpha theta after you clean things up. But when I think about it, it's not that surprising.
Right. Okay, this is fabulous. This is a wonderful presentation from somebody who's had a lot of experience, been in the field a long time, and done a lot of clinical work hands-on. So I think it's just been a wonderful passing on of that experience for all of us to consider. Rob, you have anything last?
No, thank you very much, Richard. Much appreciated taking your time. I know you're a busy guy, so we really appreciate the time and effort. I've sent you a reminder for the PDF version, and I'll get with you later on, and hopefully we'll see you at ISNR this year.
Oh, I'll be there. I'll be there.
All right.
We all will.
Looking forward to catching up with everyone. And
all right.
Thank you so much for the opportunity to do this. It's nice to put 13 years worth of work at least out there, so that I can share it with others, and hopefully they can use it to help other people.
Yeah.
Yep. Great presentation. Thanks so much.
Yeah, well done. Great job. Thank you very much.
Bye, everybody.
Have a good week, everyone.
Thank you very much.